AKI is a serious condition complicated with high morbidity and mortality, and mostly interesting in nature, associated with ischemic, septic, and nephrotoxic causes. Ischemic reperfusion injury is a common cause of AKI in clinical settings after kidney transplantation and cardiac surgery. The pathogenesis is complex, involving a cross-talking between renal and immune systems. And if this process continues, this can lead to renal fibrosis, CKD, cardiovascular disease, and mortality. And it's also characterized by exacerbated inflammatory response. Different cells are involved, including bone marrow-derived cells, endothelial cells, and epithelial cells, resulting in their activation and chemokine production. Primary insult to the kidney is initiated by pathogen-associated molecular patterns and damage-associated molecular patterns, which are recognized by toll-like receptors expressed on immune cells and renal parenchymal cells, which further exacerbates inflammatory pathways. Several components of cellular and pathophysiologic mechanisms of AKI include innate and immune cells, as well as mitochondria biogenesis, cell death mechanisms, hypoxia-inducible factor, and complement system. Proximal renal tubular epithelial cell is most sensitive to the injury due to its high metabolic rate and low oxygen tension, and also was previously believed to be the victim, but now it's known that it's one of the primary drivers of injury. Along with endothelial cells, tubular epithelial cells undergo morphological and functional changes and produce cytokines. Leukocytes and lymphocytes also infiltrate the kidney and become activated for pro-inflammatory cytokine productions. Pro-inflammatory cytokines and chemokines are counterbalanced by anti-inflammatory inhibitors and antagonists, but there is this regulated mechanism also taking place for the immunopathogenesis. We tested the roles of fractalkine and macrophages in a mouse model of ischemic reperfusion injury. Fractalkine is expressed on injured endothelial cells and is a potent chemoattractant for macrophages carrying the fractalkine receptor. So we also investigated whether macrophage depletion was protective by using liposome-encapsulated coordinate. This is phagocytosed by macrophages and causes lesions of macrophages and systemic depletion. Our results indicated that fractalkine receptor expression was increased at vascular sites close to macrophage accumulation in ischemic AKI, and inhibitor of fractalkine receptor with specific antibody decreased macrophage infiltration and provided protection against ischemic AKI. And also macrophage depletion in the kidney by liposome-encapsulated coordinate was functionally and histologically protective. There are versatile macrophage functions on kidney injury. At the initial injury phase, M1 phenotype macrophages produce various cytokines for robust inflammation. However, during the repair phase, macrophages change their phenotypes into anti-inflammatory M2 macrophages, which produce profibrotic factors and may directly convert into myofibroblasts, leading to development of interstitial fibrosis and CKD. Most of our knowledge comes from experimental work in animals, and several strategies were used to target inflammation by using depleting pathogenic inflammatory cells or targeting specific cytokines. They all resulted in favorable results in animal studies. However, this does not translate into clinical practice due to the heterogeneous nature of AKI in human beings. Kidney is also the target of complement-mediated inflammation. Complement system is activated through three different pathways. Classical pathway is activated by antigen-antibody immune complexes. Lectin pathway is activated by sugars on microbes and cell surfaces. Alternative pathway is continually activated through a takeover system at low level, but is also secondarily activated through the activation of classical and lectin pathways. These three pathways converge on the level of complement 3. And the major goal of all these three pathways is opsonization and release of pro-inflammatory aflatoxins like C3A and C5A, and finally the formation of membrane attack complex to lyse target cells. Several complement activation fragments are expressed on many host cells, including immune cells, endothelial and epithelial cells. And this complement system is regulated by proteins expressed on cell surface and plasma, C1 inhibitor inhibiting both classical and lectin pathways. Factor H is a regulator of alternative pathway. Factor I inactivates C3 convertases, but requires a cofactor, membrane cofactor protein for its action. In AKI, complement activation was shown to primarily occur within tubular interstitium and peritubular capillaries. A nice study from 1980s elegantly showed that acidic environment and ammonia synthesis promote alternative pathway activation and may also play a role in the progression of CKD, which provides rationale for use of bicarbonate to prevent acidosis and also prevent CKD progression. Among the pathways included in complement activation, alternative pathway probably plays a more important role in ischemic AKI, as indicated by increased C3 breakdown and loss of regulatory proteins. An elegant study published in JCI showed that mice lacking C3 are protected from ischemic reperfusion injury in contrast to C4 depleted mice. And factor B depleted mice also have improved protection from ischemic reperfusion injury. In human beings, C3D deposits from alternative pathway activation were demonstrated in human AKI biopsies, especially on tubular basement surfaces. Recently, lectin pathway activation was also shown to be important due to increased colectin release from ischemic renotubular epithelial cells binding fucose expressed on cell surfaces. And this lectin pathway activation is further amplified through alternative pathway via cleavage of C3. During ischemic reperfusion, there is also breakdown of endothelial glycocalyx and loss of regulatory proteins, resulting in inflammatory responses and increased coagulation. C3, C5, and C6 depleted transgenic mice were all shown to be protected against ischemic reperfusion injury in animal models. In the setting of kidney transplantation, donor-specific anti-HLE antibodies bind to their targets on endothelial cells and activates the classical pathway of complement. And this activation is further amplified by alternative pathway, ultimately leading to formation of membrane attack complex. We looked at the role of alternative pathway in an ischemic reperfusion model in mice. Alternative blockade by monoclonal antibody to mouse factor B, which is necessary component of alternative pathway, prevented generation of systemic C3A and deposition of C3B on tubular epithelium after ischemic reperfusion injury, and provided both functional and morphologically less AKI. So this also indicates the role of alternative pathway activation in the setting of ischemic reperfusion injury. So it looks like complement activation is important in the formation of AKI, but also it has some roles for the formation of CKD progression as well. CRY is a rodent complement regulator, which is similar to membrane cofactor protein in humans, and is present in endothelial and epithelial cells. In the setting of ischemia, normal polarization of CRY is lost, leading to widespread alternative pathway activation. So it was shown that CRY deficient mice are more susceptible to ischemic reperfusion than wild-type mice. And when these mice depleted of CRY and C3, kidneys transplanted into wild-type mice, there was acute activation of plasma-derived C3, leading to AKI, and then to CKD as well within weeks of time. So this all shows the importance of alternative pathway activation, both in the formation of AKI and then CKD in the long term. And this complement activation process also resulted in C3A receptor activations on monocytes and macrophages, infiltrating the kidney and the proliferation of resistant dendritic cells as well. So the increased expressed cognate receptors of these complement 3A receptor 1 and complement 5A receptor on tissue macrophages, and as well as pericytes, also is a driving force for the formation of renal fibrosis and indicating the role of intracellular complement activation in kidney fibrosis. Several elegant experiments also supported these processes. When CRY and C3 depleted kidneys were transplanted into hosts lacking C3A receptor and lacking C5A receptor, there was reduced tubular interstitial inflammation and fibrosis. So it looks like the modulating the role of the roles of C3A receptors and C5A receptors may be protective against ischemic reperfusion injury and immune cell infiltrations. So this may be an option in the future for preventing inflammation as a therapeutic target. There is bidirectional crosstalk between toll-like receptors and complement and cytokines. So as I mentioned earlier, toll-like receptors are a family of pattern recognition receptors in the first-line defense system, widely expressed on leukocytes and tubular epithelial cell. These cells prime cells to undergo programmed cell death mechanisms, causing cellular lysis and pro-inflammatory cytokine release, like pro-interleukin 1 beta, interferon gamma beta, and NF-kappa beta dependent cytokines. These pro-inflammatory cytokines events can be transmitted systematically and may also lead to extended inflammation and distant organ dysfunctions, as in lungs, heart, affected by ischemic reperfusion injury mediated extended inflammation. After AKI, the kidney has a remarkable capacity for regeneration. However, when the injury is severe or persistent, this regeneration capacity is incomplete or maladaptive and may also turn into chronic kidney disease formation. In this maladaptive kidney repair process, multiple cell types and multifactorial processes are involved, of which inflammation is a key component. If I emphasize what is going on in the interstitial and tubular cell level. There is cell cycle arrest, endothelial and epithelial mesenchymal transitions, mesenchymal phenotypic transitions into profibrotic phenotypes, and as well as release of profibrotic factors, complement activation, and metabolic changes in mitochondria. And as in the tubular cell level, there is released exosomes and also the toll-like receptor-mediated activation of NF-kappa beta and transcription of profibrotic cytokines through the activation of NLRP3 inflammasome activation. These all cause exacerbative inflammations and emphasize the role of bidirectional interplay between kidney parenchymal cells and the immune system in the formation of fibrocystic processes. Many growth factors are also involved in AKI and AKD, CKD transition, like bone morphogenic protein 7, VEGF, TGF beta 1. They are all involved in acute injury phase by eliciting inflammatory responses and programmed cell death. However, when the injured cells fail to regenerate through differentiation, this time fibrosis is induced, leading to CKD by overproduction of these growth factors. So it looks like there are dual roles of these growth factors, both in the formation of renal inflammation and injury, and also in healing processes. And when these effects are overactivated, there is stimulation of fibroblasts and pericyte proliferations, transdifferentiation of tubular epithelial cells and endothelial cells, and extracellular matrix production, leading to CKD transition. Based on this pathophysiological background, what are the clinical implications? Several biomarkers to predict AKI early was described based on their capability to reflect cell stress, structural damage, and functional alterations in glomerular filtration. Among these, the urinary markers, tissue metalloproteinase 2, and insulin-like growth factor binding protein 7 looks important. This is recently discovered inducers of cell cycle arrest and are key stress biomarkers of AKI, and they are considered superior to non-damaged biomarkers such as kidney injury molecule 1 and NGAL. These are also approved in the United States and Europe in critically ill patients to predict AKI earlier compared to serum creatinine. There is also evidence of complement activation in urine sample in human AKI. In a case control study of AKI after cardiac surgery, urine factor BA, which is an alternative pathway activation in component, was increased, correlated with AKI severity, and preceded the rise in serum creatinine. So this may also hold promise for using urine BA as a predictive or functional biomarker if supported by further studies as well. About the treatment strategies, several therapeutic agents blocking complement system is already in use in clinical practice, like eculizumab, ravulizumab, and avacopan. Whether these agents may hold promise in the setting of AKI needs to be answered by further studies. For now, several agents are being tried for prevention of rejection in kidney transplantation. Of this, C1 inhibitor, a recombinant C1 esterase inhibitor, which causes classical and lectin pathways inhibition, was shown to be protective against ischemic reperfusion injury and chronic allograft fibrosis in animal and ex vivo studies. As for eculizumab, pediatric transplant recipients randomized to single dose of eculizumab prior to kidney transplantation showed better early graft function and lower arterial hyalinosis and chronic glomerulopathy at subsequent biopsies. However, 4 patients developed flu-like illness and lost their allografts within 60 days after transplant. In adult patients, peritransplant eculizumab was well tolerated, but did not reduce the incidence of delayed grade function. As for the new drugs on the horizon, several agents are tried targeting major pathophysiological aspects of AKI with some inconsistent results of these. Recombinant alkaline phosphatase dephosphorylates pumps and dumps, and in a phase 2 trial of sepsis AKI, short-term effects regarding kidney function was negative. However, longer-term renal function and mortality was significantly improved. So some clinical trials are already ongoing, and we need to wait for the results. As for the repair agents, mesenchymal therapy, stem cell therapy, bone morphogenic protein, and hepatocyte growth factor was used due to their anti-inflammatory and regenerative effects. Favorable results was shown with hepatocyte growth factor, and there is an ongoing trial in cardiac surgery and kidney transplantation, and there are inconsistent results with bone morphogenic protein and mesenchymal stem cell therapies. However, it looks like individualized and more targeted therapies must be more important in AKI. In that aspect, mesenchymal stem cells can still hold some promise because they can migrate to areas of injury and are known to modulate local injury response primarily by paracrine-based, but lately it was shown that as extracellular vesicular delivered release of soluble factors like hepatocyte factor, insulin-like growth factor can also be effective. Mesenchymal stem cells modified by hepatocyte growth factor was shown to attenuate ischemic reperfusion injury. And macroRNAs and extracellular vesicles may also hold some promise. These are exosomes and macrovesicles are membrane-bound vesicles. They contain mRNA and microRNA that can alter gene expression, and endothelial progenitor-derived microRNA was shown to be productive in ischemic reperfusion injury. So it looks like exosome is a promising therapeutic vector to target specific drug delivery to the site of injury. Macrophages-derived microvesicles packed with dexamethasone or exosomes loaded with anti-inflammatory IL-2 10 was showed protective against renal ischemic injury. So it looks like nanotechnology for specific drug delivery may also be important in the future for treatment options. So in conclusion, AKI is an inflammatory syndrome with short and long-term serious complications. Due to its multifactorial and complex nature, there is lack of approved therapies in humans. Advances in our understanding of the pathogenesis and biomarker development and the spectrum of targeted therapies may improve prognosis in future, hopefully. Thank you for your attention.